Good evening, consultants, teachers, fellows, and colleagues on the call. You are welcome to today's meeting. Today, we start with a curriculum presentation led by Dr. Kofi Techi. We'll be presenting on ICD CRT. Kofi, your audience.
Thank you very much, and good evening, everyone. So we're going to take a look at ICD and CRT therapy, as Eugene has said, and this is an important part of modern cardiovascular care. It's important that we understand, at least we have a certain basic understanding of how things work. So here's the outline, a brief introduction to ICD, arrhythmia termination indications. Then we look at CRT, different running implantation program, and so we are starting with ICDs. So as I said earlier, the ICDs are an important part of modern clinical practice, and they are cardiac implantable electronic devices that have the ability to detect and terminate potentially malignant ventricular arrhythmia. ICDs are also said that they are able to provide pacing functions in addition to termination of the malignance of the arrhythmias. And there are two broad indications for ICDs. One is primary prophylaxis, that is, you have patients who have high risk of developing an arrhythmia, and so then prophylaxis which prevent them from developing their so that if the arrhythmia does occur, it's hydrolyzed them and disabilities them. And then the other one is the secondary, where the person has already had an event, but there is an irreversible cause or an abiding cause which you think making the risk of further ventricular arrhythmia. So in this case, you can use it as secondary prophylaxis. So just to look at the component device, we have the generator or the fan, and within this we have the capacitor, the battery, the circuit board, and the connector. And then we have the leads as well. Sorry, can I be heard?
Yes, so as I said, it's made of the generator, which has the battery and the capacitor in there. We have the circuit board and then the connector, which is what the leads will connect to. And then we have the actual leads um that that perform the shocking or the pacing. Now, the ICD leads have a shocking coil. We'll see a picture of that later. And then they also have tip and ring electrodes. So the shocking coil is for delivering a shock, and then the tip and ring electrodes are useful when pacing activity is required. So over here we have a picture of the ICD. So this is the generator, the pulse generator or the can. So here's the capacitor. Because the ICD may end up giving a shock, it needs to store energy. And so it has a large capacitor so that it can store enough energy to deliver a shock if necessary. Then we have the battery, and then this is the circuit board where you have all the electronic stuff. And then here you have the connector. This is what the lead connects to. So again, it's over here. This is the capacitor, the battery, then the electronics are in this part. And then we have the connector where the leads go. Here, so when you look at the leads, you realize that over here where the laser pointer is, this is the shocking coil. And so this is what it looks like as compared to the pacemaker lead, which does not have this coil over here. And on an X-ray, over here is what the pacemaker leads look like. So you see that you have a very thin lead with the more radio opaque tip. And then this one as well. I think this lead is dislodged, but the aim is just to look at the lead itself. So then you see that it goes all the way to the tip. But when you look in the at the ICD, you realize that this part is thicker. So this is the shocking coil component of the ICD. So if you have to see a chest X-ray and you see this, then you know that it's an ICD. So in case you get an image in the exam, once you see this thickness at the end here, you know it's an ICD. Whereas if you see this, if it's thin throughout, then you know it's a pacemaker lead. So ICDs are programmed in zones, and this is based on the cycle length. So again, just like with pacemakers, when ICDs are being programmed, it's not programmed according to the heart rate in beats per minute, but it's based on the cycle length. And to calculate the heart rate, it's 60,000 divided by the cycle length. So cycle length of 1,000 is equal to a heart rate of 60 beats per minute. A cycle length of 500 is equal to a heart rate of cycle length of 500 is equal to 120 beats per minute. So the shorter the cycle length, the higher or the faster the heart rate. And the longer the cycle length, the slower the heart rate. So the ICD is programmed in zones. So for example, you can have zone 1, zone 2, zone 3, where zone 1 will be defined by a certain cycle length at which a certain action is expected. If this action does not terminate the rhythm and the cycle length is shorter, that means the heart rate is faster. Then you go into zone 2, which also has its own instructions. So that is exactly how it works for the ICD programming. Now, the ways that the ICD terminates the rhythm is by that there are two options, either overdrive or anti-tachycardia pacing or shocking. Now, the anti-tachycardia pacing is based on the premise that in determining the underlying heart rhythm is basically a case of the fastest bidder wins. So the fastest focus or the fastest pacing focus is ends up dictating the rhythm. So with anti-tachycardia pacing, all that the device attempts to do is to outpace the underlying ventricular arrhythmia, so that now everything is dependent on the device. And so once the device stops, then it resets and then the sinus node can take over. Now, this occurs in two ways, either the ramp or the burst. We'll see pictures of that later. And then we have the shocks, which we all know about, as we are familiar with the process of defibrillation already. So here we have the burst pacing. Now, in burst pacing, the cycle length is the same for all the paced complexes. So you can see that here it's pacing at a cycle length of 320 milliseconds. So you can see that it's 320 milliseconds throughout. So this is burst pacing. Then we have ramp pacing, where you have decremental cycle lengths. So this was at a cycle length of 320. This at a cycle length of 310. This at a cycle length of 300. This at a cycle length of 290. So you realize that the cycle lengths are reducing per beat. So that gives you this kind of slope where you're having decremental cycle lengths. So those are the two main methods of 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 initiating that anti-tachycardia pacing. There's also the burst pacing with an extra systole as well. Um, so it's been so anti-tachycardia pacing is much more effective for organized reentrant ventricular tachycardia rhythms. So it's best used for patients who have monomorphic ventricular arrhythmias. It's most effective with rates lower than 188, but still maintains effectiveness up to rates of about 240 to 250 beats per minute. And typically it's a train of 8 to 10 impulses. So then the device fires 8 to 10 consecutive impulses at that fast rate. And the aim is to try and then break this tachycardia circuit so that now this circuit is no longer determining the heart rate, but rather the pacemaker or the device itself does that determination. And then once you stop, then the sinus node recovers and then takes over the underlying rhythm. Um, so it is much less effective in those with polymorphic VTs and those with ventricular fibrillation. So these people are more likely to require shocks than those who have organized monomorphic ventricular tachycardias. And it's been shown that burst protocols tend to be more effective in anti-tachycardia pacing than the ramp protocols. So the burst protocols tend to be used much more. And the rate at which that tachycardia pacing is done is based on the prevailing cycle length. So it's typically at least 85% of the prevailing cycle length of the arrhythmia. So here we have an example. We don't see much going on over here, but this part was, let's assume that this part was a sinus rhythm. Then the patient went into ventricular tachycardia over here. So you can see that this whole place, you have a ventricular tachycardia. So at this point, the ICD identifies that the patient is in VT, and based on the programming, this has been programmed to perform anti-tachycardia pacing. So you see that a burst protocol kicks in. You realize down here, these are the cycle lengths down here. So you realize down here that this is the cycle length of the VT, and then the burst pacing is fixed at 230 milliseconds throughout. And at the end of the burst pacing, sinus rhythm is restored again. So there's a situation where the anti-tachycardia pacing worked in, was able to terminate the ventricular arrhythmia successfully. And we have another one here, and this is much smaller. But here we have another sinus rhythm here, then a ventricular tachycardia starts, and then you have the anti-tachycardia pacing kicking in. Over here, it appears to terminate it. So here it's terminated in this first example, that's in A. Now coming to B, again, you have a sinus rhythm. Even though this is labeled as VT onset, I see P waves there, so I'm not convinced of VT, but at least it still serves the purpose for which we want to understand it, so we'll take it as a VT. So you can see here that you have a very fast heart rate, and the device picks it up, so it initiates anti-tachycardia pacing. So you realize that you have a burst of anti-tachycardia pacing, but you come down here and realize that the patient is still tachycardic. So that means the first anti-tachycardia pacing didn't work. So now it moved to zone 2, and you have a second round of anti-tachycardia pacing at an even shorter cycle length than the first one, because now it's like the first didn't work, so let's go faster. Let's try and then capture it. So then second one goes on, and VT is still standing strong. So you see here the patient is still in VT. Then now it's been programmed that once it enters zone 3, deliver a shock. So over here, it delivers a shock at 4.8 joules. And then now you have sinus rhythm restored. This is an ectopic beat, but then now you have sinus rhythm restored. So the shock was able to terminate it. So this is how the arrhythmia termination occurs in zones, both with anti-tachycardia pacing and delivery of shocks. So there are three types of ICDs. You have the transvenous, subcutaneous, and then the wearable ICD. This is what I'm sure most of us are very familiar with. This is the transvenous ICD. So you see the ICD lodged in the subcutaneous pocket over here, and then you have the lead coming in. So this is a single chamber ICD. You can see the shocking coil over here in the right ventricle. And so here you have the same thing being shown here. Now, transvenous ICDs may be single or dual chamber. So just like pacemakers, you can have a dual chamber ICD. But it's important to remember that the ICD's aim is to terminate ventricular arrhythmias. So even though you may have a dual chamber ICD, the atrial lead is not aimed at terminating atrial arrhythmias. Rather, it is there to improve sensing, because the ICD through the ring and tip electrode may have what we call far field sensing, where it will sense electrical activity in the atrium and respond to that. So that can end up giving the patient inappropriate shocks, causing a lot of pain and reducing quality of life. So when there's an atrial lead in there, that improves the sensing of what's going on in the atrium so that the device is able to better characterize the atrial activity and reduce the chances of far field sensing from ventricular lead, which relate to inappropriate shocks. Um, Transvenous ICDs are also useful for patients who require pacing, because as I said, the ring and tip electrode help with pacing activity. And typically it's placed in the RV apex, but then it may be positioned in other places if the source of the arrhythmia has been localized there. For example, if you identify that, if you're able to localize the ventricular tachycardia to the RVOT, then there's the possibility of putting the electrode, the ICD lead in the RVOT and delivering the shock there for maximum benefit. However, it can still be put in the RV apex and will still be able to control it. Just I may do so at a higher energy, but then it's still effective. So it's not really necessary to go and put it in different places. And as I explained already, the dual chamber improves atrial sensing. Then here we have the subcutaneous ICD. Now, the subcutaneous ICD, you have the pulse generator sub placed in the along the rib cage laterally, so sort of in the flank, and then you have a single electrode which is placed parallel to the sternum on the left side. Um, so on an X-ray, this is what it will look like. And excuse me, so this is what it will look like on an X-ray, both AP and lateral. So again, here you can see the coil over here, the shocking coil. And then in the lateral view as well, you can see the shocking coil over there. Now, the subcutaneous ICD has a much larger pulse generator than the transvenous ICD. And this can be explained by the fact that the transvenous ICD is directly in the heart and it's anchored to the myocardium. So then it needs less energy to induce or to cardiovert as compared to the subcutaneous ICD, which will have to deliver the charge through subcutaneous. It's under the skin, so through subcutaneous tissue, through muscle, fascia, through muscle, pericardium, epicardium, and all that. So then this one will need much more energy, for which reason it has a larger capacitor and therefore a larger generator. So as I've said, it's bulkier than the transvenous ICD due to the higher energy required. Um, the other thing is that the subcutaneous ICD is not able to pace. It's able to give some initial pacing after shocking, but it can't be used for regular pacing. So that limits its use in the sense that if you have a patient who may concomitantly need some regular backup pacing, then the subcutaneous ICD is not the right choice. That one you'd have to go with a transvenous ICD. However, because it is subcutaneous, there's less procedural complexity, there's less radiation, you don't have a risk of systemic infection because there's no device inside the heart. Procedure time is shorter, and it's easier to remove or to extract a lead, just as it is for example, for extracting a lead for a what's that thing called a tunnel line. It's much easier because you don't need to go in and manipulate and risk vessel rupture and all that. The one other drawback is that because it is subcutaneous, there's a chance that it can confuse myopotentials for electrical activity. And so, if, for example, you have someone who has a lot of shivering artifacts and is picking that as the electrical activity, then they may pick that as an arrhythmia and end up unnecessarily delivering a shock. So here we have a comparison between the transvenous and subcutaneous ICDs. Um, so for transvenous, you can do it under local anesthesia because once you're in the vascular space, there are no pain receptors in there, so then the patient doesn't feel pain. But subcutaneous ICD will probably have to be under deep anesthesia because all your dissection and manipulation is within the subcutaneous tissue, which is rich in nerve endings. So then that will tend to be more painful. Um, Transvenous, you will need fluoroscopy. Subcutaneous, you don't. Transvenous will give you an intracardiac ECG, whereas the subcutaneous will give you a surface 12 lead ECG kind of reading. Um, Transvenous ICDs may give you inappropriate shocks from far field sensing, as you'd see in an SVT, whereas subcutaneous ICD may end up sensing the T wave as a ventricular complex and may also identify myopotentials and therefore may give inappropriate shocks. Transvenous can do antitachycardia pacing, subcutaneous cannot. Transvenous does lower energies than subcutaneous, and transvenous ones have a higher risk of systemic infections as compared to subcutaneous ICDs. Um, so this is another one that's another comparison between the two of them. Then we have the third one, which is a wearable ICD. So this is what it looks like on X-ray, and this is what it's actually like on the patient. So you have um, three electrical circuits, two at the back and then one somewhere in front here, connected to this device. So it's also able to serve as a kind of recorder or an event monitor, more or less. Um, so this is used in specific situations. The wearable ICD is not an end in itself. It's a temporary measure, and it's usually a bridge to definitive ICD therapy and may also be used transiently when support is required. For example, if you have a patient who needs an ICD, but the patient is being treated for something like infective endocarditis, you cannot go and put in an ICD, a transvenous ICD, because with all those vegetations over there, one, you're going to contaminate the lead, and two, you're probably going to embolize a vegetation or two. So for this patient, you will need to use a wearable ICD while you complete your treatment with the antibiotics. And then once it resolves, then you can put in the intravenous ICD, the transvenous ICD, and then take off the wearable one. Again, in some situations, a patient may have an arrhythmia and you want to confirm whether the person has an irreversible cause of the arrhythmias. For example, someone has an arrhythmia, you suspect that it may be, for example, Brugada syndrome or arrhythmogenic RV cardiomyopathy, but you're not certain, you're still investigating. But the person is having arrhythmias, and so you still want to give the person cover while you confirm the diagnosis and take a definitive decision. So the wearable ICD can be used while you sort out all the diagnostic issues. And then once you make that diagnosis and you are certain that the ICD is needed, then you go ahead and put in the ICD. Um, there are some situations where people may transiently have arrhythmias. For example, those with acute myocarditis, or even those who have acute myocardial infarction. And we know that in an post-acute myocardial infarction, you need to wait at least 40 days before you will consider putting in an ICD if the person is still having incessant arrhythmias. So over this period, you can use a wearable ICD so that it gives support while you wait for the acute issue to resolve before taking a definitive decision. And again, for people who have been listed for transplantation, who have malignant arrhythmias, while waiting for that, you can use a wearable ICD. So the wearable ICD is not an end, it's not a destination in its own, but it's just a stopgap while you plan or while you optimize your patients to be ready for the transvenous ICD. So indications for ICD therapy, first thing is that the patient has to have an expected survival of more than 1 year. If the patient doesn't have an expected survival of more than 1 year, then you don't even think of an ICD. Secondarily, so for secondary prophylaxis, you have patients who have survived a cardiac arrest due to ventricular arrhythmia with a cause that you think will lead to recurrence. So this is usually for the heritable causes of arrhythmias like Brugada, hypertrophic cardiomyopathy, ARVC, long QT syndrome, CPVT, etc. And then post-MI as well, some people may have persistent arrhythmias after the 40-day period, for which reason you may want to put on an ICD. Those with heart failure with an EF of less than 35% who are symptomatic despite GDMT, you would also consider putting in an ICD. But it's important to remember that the ICD is not a treatment for arrhythmias. It is to prevent sudden cardiac death from the arrhythmias. So even if a patient is on an ICD, you still need to go ahead and then treat the patient with the appropriate antiarrhythmic therapy. Otherwise, the person will keep getting shocks, which will impact their quality of life. So just a look at some of the evidence. We can have a closer look at it because the slides will be shared. But as I said, quality of life should be at least 1 year. You can use a subcutaneous defibrillator if you do not think you will need pacing therapy, cardiac resynchronization, or anti-tachycardia pacing. This is when you can use a subcutaneous ICD. But if you will need pacing, if you need CRT, if you need ATP, then it is not the choice for you. And then, yes, so ICD class 1 indication, if you have VFib or VT with hemodynamic compromise in the absence of reversible causes. So if you have, like, for example, as I said, the heritable ones, you will consider that. Sometimes, and when you are putting in an ICD, you still need to remember the regular therapies, especially for supraventricular tachycardias. So if necessary, you may need to do a catheter ablation if the antiarrhythmics are not controlling it, and if the patient is having recurrent shocks likely due to far field sensing. Yes, so pharmacological therapy is still important in these patients. And the wearable cardioverter defibrillator should be considered for adult patients with a secondary prevention indication who are temporarily not candidates for ICD. So they're not ready for it, but as a stopgap, use the wearable defibrillator until then. These are a few of the studies that have supported the use of ICDs and shown that they have mortality benefits by preventing sudden cardiac death. And so we can take a closer look at them later. And this is another list of studies, or this is a more comprehensive list compared to the previous one. But the ones we really need to note are the MADIT 1 and 2, and then the SCD heft. SCD heft showed that in both ischemic and non-ischemic cardiomyopathies, ICDs reduced the incidence of sudden cardiac death. So then we go to the second part of the presentation, which is CRT, cardiac resynchronization therapy. And it's also referred to as biventricular pacing because the CRT involves the use of leads in both the right ventricle and the left ventricle, in addition to the right atrium. And its aim is to correct the desynchronous contraction between the ventricles. And by doing so, it improves the efficiency of contraction and cardiac output, and also improves quality of life and treatment outcomes in heart failure. CRT may be used in conjunction with ICD therapy in the sense that you may use an ICD lead as part of the CRT therapy, in which case it's called CRTD, that's CRT with a defibrillator function. But if you use just pacing leads, then it's a CRTP, that's a CRT with pacing function. So when we talk of desynchrony, we have electrical and mechanical desynchrony. Electrical desynchrony is picked up on the ECG, and what it means is that, or the hallmark is that the QRS segment is broad, the QRS complex is broad. And you know that the QRS is a composite of RV and LV contraction. So when you have a conduction abnormality, we know that the impulse from the AV node goes down the His bundle and then down to the left and right bundle branches, such that there's LV and RV contraction at approximately the same time. Now, when you have a block in this transmission, most notably in the left bundle, then the activation current goes down the right ventricle and then retrogradely enters the left ventricle. So the right ventricle basically finishes contracting before the left ventricle starts contracting. And so this causes a desynchrony between the two. So you see here that you have a broad QRS complex, and here it is showing where the RV is starting contraction, and it shows where the LV is starting. So there's quite a lag between the two. Then here, RV has finished contracting and is relaxing. LV is still in the contraction phase, and it starts relaxing over here just shortly before atrial systole. So that is where the mechanical desynchrony comes in. Now, the desynchrony occurs at three levels. It can be between the atrium and the ventricle, which is atrioventricular desynchrony. It can be within the ventricle, that is intraventricular desynchrony. And with this, what happens is that you have contraction of the septal wall before the free wall. So, for example, again, if you have the activation current going down the right bundle, it depolarizes the septum first, and septum will contract, and then it finishes depolarizing the RV before retrogradely entering the left to depolarize the left posterior wall or the left free wall. So then what happens is the septum contracts much earlier than the free wall. So you don't have a concerted effort to push blood out. And so that will end up resulting in increased LV end systolic volumes, which will culminate in higher LV end diastolic pressure, increased myocardial wall stress, cause prolongation of mitral regurgitation even into diastole, and ultimately culminate in poor quality of life. So that is intraventricular. Then we have interventricular between the RV and the LV. So that is what has been described over here. So these are the levels of the synchrony that we have. And so over here we see um, a normal ECG, a normal QRS. The QRS width is 40 milliseconds over here. And this is a normal sized heart and a dilated heart. And I can see that even in the dilated, like for both the normal and the dilated heart, there is fairly equal activation. So here we see the activation time. So looking at the septum, that's a light blue over here, and the light blue goes all the way to the posterior wall. Okay. And then you see that over here as well. So then there's adequate activation. So you still have the septal and ventricular, septal and posterior walls or free walls contracting together, so it ejects blood out. Now over here we have a left bundle branch block with a QRS of 126 milliseconds. So again we have this color coding here. So then you can see that the septum here is blue, so it is contracting pretty much immediately. But because of the left bundle branch block, the RV contracts first, and then retrogradely the LV free wall. So you can see that the septum has contracted after about about, let's say this should be somewhere around 30 milliseconds of activation. Yet it took 130 milliseconds for the free wall to contract. So it affects the effective ejection of blood. And this happens in both the normal and the dilated heart where there is a bundle branch block. So over here, you can appreciate that here the normal the normal QRS width had a higher ejection. But then over here, the inotropy reduced by 27% because of the desynchrony, and relaxation occurred much earlier in the normal one compared to the abnormal one. And this is what happens when you have a bundle branch block that causes desynchrony. Just to put it into perspective, this also shows the same thing that we've just talked about. So you can see the electrical activation over here. That's up to 30 milliseconds. And then by the time it gets to the free wall, it's 90 to 120 milliseconds. So it's much, much later. So you can see that when the septal wall shortens to contract and then stretches to relax, when the septal wall is stretching to relax, that is when the free wall is now shortening to contract. And you see that in this image here. So that desynchrony affects the adequacy of ventricular contraction. So in summary, the synchronous electrical activation results in mechanical desynchrony, which causes a mechanical disadvantage and reduced efficiency, increasing myocardial wall stress and impairing myocardial perfusion, therefore leading to adverse remodeling and asymmetrical hypertrophy, which causes neurohormonal and sympathetic activation. Because if you're not pushing enough out, then you're going to activate baroreceptors and lead to RAS activation, and the whole heart failure cascade begins. This diagram also just explains the same thing in another way, so we can take our time and look at it when we get the slides. So implanting a CRT uses 3 leads, as I said earlier: RA lead, RV lead, which is RV apical, and then coronary sinus lead. Now, the RV apical lead, as I said earlier, may have a shocking coil, in which case then it's a CRT-D, or maybe just a normal pacer lead, in which case it's CRT-P. And then the coronary sinus lead is put in a lateral venous branch so that it goes far towards the LV wall, and that's for LV pacing. When putting it in, you start distally and move proximally so that three leads are used for a CRT: RA lead, RV apical lead, and then coronary sinus lead. So the RV apical lead may just be a regular pacing lead, in which case you have a CRTP, maybe a lead with a shocking coil, which makes it a CRTD. And this is put in the RV apex. Sinus lead is put in a lateral venous branch. So that goes to the bulk of the left ventricular wall to pace the LV. And when it's being implanted, it's done from distal to proximal. So you start from the right ventricle, then put in the coronary sinus lead, and then the right atrial lead, which goes into the right atrial appendage. The reason for doing this is you don't want to disturb what you've already put in, because if you put in a lead and then you go manipulating, it may come out and then you have to start again. And that's where defibrillation is anticipated, then the RV lead will need to be the shocking coil. So this X-ray shows a CRT. Here we see the coil here, so that means this is a CRT-D. So this is the RV lead. This is a coronary sinus lead moving towards the left ventricular side, and then the right atrial lead that's going into the right atrial appendage. And then here we have the pulse generator, or the CAN. So CRTs are set to a tracking mode, commonly DDD. And the reason you want to track is that you want to, in addition to optimizing ventricular inter and intraventricular synchrony, you want to ensure that there's atrioventricular synchrony. So then you need to track atrial activity so that there is an appropriate response by the ventricles. and the aim is to get at least 95% pacing. With a pacemaker, once you have more than 40% pacing, then we say that person is likely to be pacemaker dependent. But with a CRT, you want the person to be pacemaker dependent because that is what is ensuring that you have the synchrony. Once you have a shorter percentage a lower percentage than this, then that means that your synchrony is not optimal. So A sensing will trigger V pacing to ensure that there is appropriate AV synchrony. So a CRT will reduce the synchrony and improve diastolic filling, which will improve LV and RV cardiac output, decrease mitral regurgitation, and decrease LV filling pressure. This ultimately reduces the end diastolic volume and the end systolic volume and causes reverse remodeling. So while the desynchrony will cause remodeling, the resynchronization will reverse that remodeling so that the LV is functioning well. So indications for CRT, it's useful for patients who have an EF of less than 35% in the presence of a complete LBBB with a duration of more than 150 milliseconds. For those with a QRS duration of 130 to 150 milliseconds, it may be considered in certain situations. And there's less evidence supporting the benefits in complete RBBB. But if the person has persistent symptoms with a complete RBBB despite the GDMT, then there's room to consider a CRT. So again, here we have the indications. Class 1 is EF of less than 35%, carries duration more than 150, LBBB morphology. You can also consider it if you have EF of less than 35%, QRS 130 to 149, LBBB with symptoms despite optimal medical therapy. Once you're going to consider a patient for ICD therapy, you need to ask yourself whether the person will benefit rather from CRT, in which case you do CRT, so you have both resynchronization and ICD. Even though there's room for CRTP and CRTD, CRTPs are not put in as much as CRTDs because generally, by selection, those who will tend to need a CRT will likely have a risk of an arrhythmia. But if you're picking people who have an EF of less than 35% with a broad QRS, these are people who will have a higher risk of developing arrhythmias. So rather than putting in a CRT, which will just pace, you'd prefer to do a CRTD. So they tend to be put in much more. Importantly, those with a QRS duration of less than 130 are not really candidates for CRT because there's little evidence in support of that. And then here we have a few more indications which we can go through and when we get the slides. So I should think this ends the presentation. And candidates who are, yeah, so okay, I've talked about this already. So those who are candidates for an ICD who also need a CRT, you do a CRT-D for this patient. Yeah, so thank you very much, and I'll take any questions that you may have. Thank you.
Thank you very much. And I think your thank you slides says it all. I'm sure all the people, colleagues and consultants listening who have listened to this presentation are smiling as your end slide is smiling. We are very grateful, Kofi, once again, and as always, very succinct presentation. And at this point, we want to say thank you. Let's show appreciation to our presenter. Then we open the floor for questions and contributions. Then we go to our consultants for the final word. So kindly unmute and ask your question. All right. So we have a question. For some reason, today Dr. Makorede doesn't want us to hear her voice, so I'll read it on her behalf. He says, "Thank you for the presentation. Please, can you re-explain the anti-tachycardia piece?" Kofi.
Okay. So the principle of the anti-tachycardia pacing is that generally the um, impulse or the pacing impulse that has the fastest rate tends to dictate the rhythm. Um, so then when you have an ICD in, the first line of attempting to correct the tachyarrhythmia is to do anti-tachycardia pacing. Now, with anti-tachycardia pacing, what happens is that there are two protocols. There's the ramp and the burst protocol. Um, so with the burst protocol, you have a fixed cycle length at which you are pacing faster. Whereas with a ramp, you have a decremental one. So then you have the cycle length reducing each time, meaning each time you are going faster. Now, what happens is that in anti-tachycardia pacing, you would typically the device will typically fire about 8 to 10 impulses at that fast rate. Now, when that happens, what it seeks to do is it seeks to block this reentrance rhythm that is leading to the tachycardia. So then it is most effective in those who have organized monomorphic ventricular tachycardias, because these are commonly due to reentrance rhythms. So once you do the anti-tachycardia pacing, then it tends to break the cycle and then the device takes over the pacing. So that now when the device finishes giving its consecutive complexes and stops, then the heart is electrically silent and then the SA node can recover and then take over the contractility. So here there was an example where you had the VT and the anti-tachycardia pacing came in. So then it paced fast. And then once it stopped, so at this point, it was successful in terminating this rhythm. So then once it stopped, then the SA node recovered and sinus rhythm took over. In this one, we had the tachyarrhythmia. ATP pacing came in, but the patient was still tachycardic, so it failed. So then it went to zone 2, where it gave the impulses at an even faster rate. And after that, it still didn't work, for which reason now it had to shock. So typically, when it's being programmed in zones 1 and 2, it tends to be anti-tachycardia pacing. And if it fails to capture the rhythm, then it would end up delivering a shock. That is typically how it works. So I hope I've explained it well. Thank you.
Thank you. Thank you very much. It's clear.
Thank you very much. Do we have any other question or contribution before we go to our teachers and consultants on the call? Okay, whilst we wait, Kofi, is there a risk of anti-tachycardia pacing itself causing a VF in an attempt to abort a VT?
Well, so if you have normally if you have an off T and you deliver an impulse on the T wave, then there is that risk of degenerating into a ventricular fibrillation. However, for those with VT, um, the, the ventricle doesn't really repolarize as it should. So I won't say that there's 100% no risk, but I think because of how tachycardic the patient is, that risk is minimal. That's what I think, but I'm not 100% sure.
Thank you. Thank you. So I think at this point, we go to our teachers on the call. So we have Dr. Ayodeji Stevens on. Good evening, sir.
Yeah, good evening, Chivo. Dr. Kofi, that was a brilliant presentation. It was a brilliant one.
Thank you.
Well delivered. And well, just like the stuff is drawing nearer, and I know we're more prepared. Though ICD and CLT will definitely come across it. Either is a multiple choice, you will definitely call, and the ICD, the ischemic and the non-ischemic indication. And there's no way you can talk about ICD without talking about electrical storm. So you must know about, it can be a station in horror, management of a patient with an electrical storm. And then you want to investigate, look for the correctable causes, are there electrolyte imbalances and all that. And then you want to give medications and all that. So you must know, you must go and read about electrical storm, the definition in a patient without ICD, and definition in a patient having an ICD. I know patient with ICD, when you have a greater than 3 shocks in 24 hours, that's an electrical storm. And the management, so you must be very conversant with it. Thank you. And then as a procedure too, you must know the CRT and the indications.
Thank you
Thank
very
you.
much. Thank you very much. Good evening, Dr. Ojo.
Good evening.
Good evening, sir. Please, any
Good evening.
contributions for us?
Hello, Dr. Eugene.
Yes, sir. Please, we can hear you.
Yes, well, it's been well discussed, and I also want to appreciate Dr. Adeji's contribution. So, the key question, particular yet. So, when we are discussing ICD, it will be part of the presentation. By and large, apart from that, there's no other comment. Thank you. Well done.
Thank you very much, Kofi. Do you want to have give any comments on the electrical storm? Is there any comments you want to give on that?
Also for electrical storm, it's the presence of or the occurrence of more than 3 VTs in a given 24-hour period, and it's usually life-threatening. You would first want to to rule out the potential causes. So you look for ischemia, electrolyte imbalances, and then you would want to you'd want to give the antiarrhythmic therapy. If that's not able to control it, then you consider the device therapy like the ICD. If that's still not working and the patient is still having recurrent VTs and having recurrent shocks, then surgical therapies like the stellate ganglion block also come in to diminish the sympathetic stimulation. But yes, ICDs are important are an important part of managing VT storm, electrical storm. Just that it's important to remember that the ICD is in itself, it's just there to prevent the issue from causing sudden cardiac death. So then the question is, what exactly is the issue? You have to try and then correct the underlying issue so that the ICD just becomes a bystander waiting for the occasional breakthrough. Thank you.
Thank you very much. Thank you very much. Once again, thank you. Thank you. We are grateful. At this point, we'll end our presentation. Then we'll continue with the MCQs. Dr. Charles Okori will take over that and moderate. Thank you very much.